So this was kind of born out of a cohort of patients that were misdiagnosed as seronegative generalized myasthenia gravis and was on a lot of immunosuppression for a long, long time. And so we tried to look back and see what were some pitfalls during that diagnostic process and what can we do better, especially since there are so many new immunotherapies out now that really open the options for seronegative patients.
And I think our biggest sort of outcome of this paper is trying to propose a new diagnostic algorithm that hopefully should help improve the positive predictive value of your diagnosis.
The part that I'm having a lot of interesting conversations today with other clinicians is how do you approach this, right? And how do we come up with an algorithm? And what's the proper way of trialing immunotherapy? And how many therapies do we try? And how do we know which one works? How do we know if it's true disease and we just don't have the right treatment? And how do we know if we got the wrong diagnosis?
Yeah, so we were looking at measures that measure the eye symptoms of myasthenia gravis, like diplopia and ptosis. And we looked at a bunch of different measures and compared them with each other, their validity, and then also looked at the ocular portion of the myasthenia gravis impairment index. The ptosis portion correlates with the ptosis exams, the diplopia with the diplopia exams. We also showed the importance of self-reported questionnaires versus exams. Because of the fluctuating nature of MG, it's hard to capture the full disease severity in a one-time point examination. So I hope that we'll figure out a way to better classify the disease severity for ocular myasthenia gravis. It's hard to measure and really impacts people's quality of life. So developing a better method for that.
So we're doing AAV-mediated gene therapy for congenital myasthenic syndromes, and we're working with a CoQ deficient mouse model and in hopes of re-establishing the CoQ protein in these mice using an AAV vector.
So we took CoQ deficient mice and injected them with our AAV treatment at around 1 month of age. We then tracked them for 12 weeks. We tracked their behavior and motor performance improvements. We tracked their physiological improvements with repetitive nerve stimulation. We then confirmed that all of the improvements that we saw were due to the protein restoration, our treatment, and we proved that our treatment currently does not reach toxic levels. So overall, we're actually really hopeful that our results can encourage our specific treatment to be used in humans with CoQ CMS, because so far it's very effective, potentially curative, and we haven't found any significant toxic side effects.
So what I would do right now is I'm working on a galactose treatment in a GFP21 CMS mouse model. So basically what's significant is that we've found a mechanism for disease. We found that the deficient glycosylation can be rescued with galactose treatment, and galactose being a very relatively inexpensive treatment chemical would allow for treatment in the future for patients at a very low cost.